Good afternoon. Welcome to the January 2016 CCI bi-monthly call. Before we begin our presentation, I just want to do a few housekeeping items. If you can hear me fine, please press 1. If the volume is fine, please press 1. If you can't, please press 2. Great. It looks like we are good with volume. Just a reminder that at the end of the presentation, we'll have a chance for general questions. If you have a question at that time, just press 1, and we will get your question through. Today, we are joined by Sarah Brooks, Deputy Director for Healthcare Delivery Systems at the Department of Healthcare Services. We'll also have a presentation in a few minutes from folks from the Health Plan of San Mateo. But now let me turn it over to Sarah.
Thank you. Good afternoon, everybody, and thank you for joining us today. We have a number of items for today's call. We'll be covering the budget, field research data, SCAN Foundation case studies. As Sapan mentioned, we have San Mateo on to provide an overview of some great work that they're doing, RTI international reports that recently were released, an update on enrollment, also an update on a piece of our outreach efforts, and then an update on materials in general. And then, of course, finally, we'll open it up for questions and answers. So to start with the budget. So the governor's proposed budget, which you all know was released earlier this month, in it's a coordinated care initiative, which does include CalMediConnect, and as you know, is a historic undertaking to help improve the lives of low-income seniors and people with disabilities in California was included. The program was developed with intensive consumer and stakeholder input and is just one building block toward our overall goal to improve health outcomes and spend our healthcare dollars more wisely. The state budget continues the CCI, Coordinated Care Initiative, and CalMediConnect in 2016, reflecting the administration's commitment to that important goal. Now, as you may know, under current law, the CCI is required to generate savings in order to continue. While it is still too early in the life of CalMediConnect to have a complete picture of how coordinated care can help improve quality of life and reduce costs, the calculation of savings generated by the CCI takes into account many factors, some of which are external to the CCI itself. Those include the expiration of the Managed Care Organization Tax, or the MCO tax, at the end of June, which is a net loss of $1.1 billion in revenue to the state, higher than anticipated costs of the IHSS program, as the result of changes in federal regulations related to overtime, an increase in the state's minimum wage, and the state's MOE, or maintenance of effort provisions in statute. And then also enrollment delays, lower participation rates, and a lower than anticipated share of federal savings. The scheduled expiration of the MCO tax has a major impact on the fiscal analysis. As of today, the MCO tax is set to expire at the end of June. Legislative action on the MCO tax would require revised analyses. While there is some uncertainty around these important factors that I just talked about and that impact that savings analysis, CCI and CalMediConnect will continue to operate in 2016. So moving on to rapid cycle polling of Medicare and Medi-Cal individuals by the Field Research Corporation. So DHCS has been working with community partners and CalMediConnect plans to help share information about the program with eligible beneficiaries and to educate physicians, caregivers, and other trusted sources of how CalMediConnect and coordinated care can improve the lives of their patients and loved ones. DHCS has been open about the challenges that have come with trying to integrate two very different healthcare systems in a way that provides improved and better coordinated care, and also challenges other states have faced as well. And we have met those challenges head-on, always keeping the beneficiaries we serve at the heart of our work. The good news is that early evaluation data shows the beneficiaries enrolled in CalMediConnect health plans are confident in and satisfied with their care, so they like the program. In December, the Field Research Corporation released the second round of data in their rapid cycle polling, which evaluates the experience of beneficiaries in and out of CalMediConnect. This second round of data continues to show that an overwhelming majority of beneficiaries are satisfied with CalMediConnect and confident in their care. So we've seen two different rounds that show similar responses in terms of beneficiaries' experience and understanding and feelings about the program. Beneficiaries in CalMediConnect plans are satisfied with their choice of doctors at 78% and hospitals at 77%, the way different healthcare providers work together to give them services at 78%, the amount of time doctors and staff spend with them, 85%, and the information provided by their plan to explain benefits to them, and that's at 73%. 79% of beneficiaries were confident that they can get their questions answered about their health care needs. The data also shows us what we can work on. Transition issues often led to early disenrollment from CalMedi Connect, but those who stayed enrolled were satisfied with how issues were resolved. Beneficiaries who opted out were wary of change in current health care services. That was at about 86%, and losing their doctors, 70%. Other evaluation efforts have shown that beneficiaries often lack awareness about CalMedi Connect benefits, including the availability of a care coordinator or continuity of care. We at the state here will continue to work closely with our partners, our plans, providers, and stakeholder communities to continuously strengthen the program and address issues. At the same time, the HCS remains concerned about the participation rate in CalMedi Connect. For CalMedi Connect to be successful over the long term, more eligible beneficiaries need to choose to participate in the program. So we really need to get the word out about the satisfaction of beneficiaries in it. The HCS has been working with community partners and CalMedi Connect plans to help share information about the program with eligible beneficiaries and to educate physicians, caregivers, and other trusted sources on how CalMedi Connect and coordinated care can improve the lives of their patients and loved ones. Together with the field polling results in December, SCAN Foundation also released multiple case studies of individuals' successful experiences in coordinated care. A Place to Call Home and Thriving in Her Community are two case studies that the SCAN Foundation did release, and full details of those stories are found on their website at thescanfoundation.org. SCAN Foundation will also be publishing additional case studies showcasing the promise of coordinated care in 2016, and we look forward to reviewing those and hearing about the beneficiary experience while in CalMedi Connect. So speaking of success stories, we want to turn it over now to Health Plan of San Mateo for a few minutes to talk about their community care settings pilot. Today's presenters include Chris Esguerra, who's the Deputy Chief Medical Officer at Health Plan of San Mateo, and Ed Ortiz, who is their Chief Network Officer. So with that, I will turn it over to them to share their exciting story and information with you all.
Wonderful, thank you, and thank you for an introduction, Sarah. So it'll just be me today, and again, I'm Chris Esguerra with Health Plan of San Mateo, the Deputy Chief Medical Officer, and I'm going to talk to you a little bit about our community care settings pilot, that we're quite proud of this pilot and how it's been helping our members. Now, this pilot falls in the continuum of our care coordination complex case management program as essentially the highest intensity care management program. And its focus is to deinstitutionalize and promote community living for our vulnerable members. In addition, it's actually a testbed for our incremental services and tools, as well as the catalyst to actually help reduce and even get rid of the silos that we are noticing vis-a-vis other various services in the community with whom we partner. Some of the unique features of this for our members is we do have and provide intensive case management with significant touches and face-to-face contact. The ratio is about one case manager who's a social worker to about 20 members. There is a housing services and retention component, and I'll get more into that in a bit, as well as a multidisciplinary core group team that does the care planning and oversight. In this team, it's quite large. We have over 25 participants. We have representation from county agencies, such as behavioral health and aging and adult services, in addition to our contractors as well as HPSM staff and physicians. In really utilizing our care plan options, the community care settings pilot deploys whatever services are necessary to help our members migrate out of or avoid long-term care residency. The ultimate goal is to help reconnect them in the community and bring them back to the community. The pilot structure, we have operated it in such a way that HPSM is the organizing entity, and we have multiple partners in this. We have two main partners. One is the Institute on Aging, and they provide the intensive case management and oversight for our process. Brilliant Corners, another organization, is our housing services and retention provider. Of course, the other partners that are part of this effort are our medical services and providers, so essentially our home health agencies, our primary care providers, our specialists and clinics, as well as our community and county-based resources. And I had mentioned that we work very closely with aging and adult services, specifically their IHSS program, but also their multi-purpose senior services program, or MSSP. In addition, we also work closely with our community-based adult services, our CBAS centers, as well as behavioral health. What we have done is try to leverage a number of resources to support these operations. So of course, I'd mentioned some of our county programs. In addition, we have used it or taken advantage of state 1115 waiver programs such as the assisted living waiver, in-home operations, and things like that. Of course, we try to maximize the health benefits as much as possible for these members and care plan optional services. And we do have a bit of local funding to assist in the effort. I had mentioned earlier about our goal of deinstitutionalization or preventing that. And in doing that, what we have done is segmented our population to be very focused and to be clear about who it is that we're working to have maintain in the community or return to the community. And we have those three targets in our population. So one segment is our long-term care residents. And through a needs assessment that occurred several years before, we identified about 10 to 30% of folks residing in long-term care settings are actually able to migrate to lower levels of care. And this was through our assessment talking to a lot of our facilities. The other two buckets are actually related to diversions. So one is the skilled nursing facility diversion. Usually there is an acute health incident that is prompting a change in health or functional status and putting the person at risk. And what we want to do is prevent them from staying longer and being institutionalized and unfortunately learning the dependency that occurs in that, and we want them to get back into the community. And then the other segment are community diversions. These are folks that are identified as struggling in the community or at risk due to, as identified through certain behaviors. And what we want to do is provide extra supports to continue to maintain and extend their independence. One of the other reasons why we've done this in really looking at long-term care in particular is we also know that it was definitely for our area in our county, we have had a shortage of adequate beds. And we also sought this pilot to be able to then free up that capacity to be able to move things along in this continuum of care. Another way for us then to take a look at what members who are referred, how we're actually going to prioritize and help them move along, we have a case mix indexing tool that we use to determine eligibility, population fit, and ensure that we're continuing to meet the goals of the pilot itself. How we engage with our participants, our partner, Institute on Aging, they are the ones that begin this process. We've done a lot of work in our community to talk about the pilot, and as a result, we have a steady stream of referrals, and that starts with an intake form, of which then it's evaluated and leading to an assessment by the case manager, which is a complete assessment and presented to that multidisciplinary care team core group that I described. And from that, that group makes the decision of what is the most appropriate level of care and services to actually help this person with input from multiple agencies and stakeholders. A care plan is created, and we get to work. And it actually takes us about 9 to 12 months to get someone in an institutional setting through discharge. And you can imagine that there's a lot of preparation for that. After the discharge and returning back to the community, we stick with them for another 9 to 12 months, really to help them build the skills of maintaining in the community. And we see these phases as the implementation phase of the post-discharge. We want to make sure that they're engaged with their primary care provider, the home is set up in such a way that's safe and manageable for that member, and that we're helping reconnect them to the community. The stabilization phase is helping them build problem-solving skills and other skills development and manage any crises that would occur. The final phase is transition phase, and we try to make sure we resolve any other unmet goals, continue to promote independence, and ultimately this member gets transferred to our routine complex case management pool, which exists within the plan itself, and our nurses manage the member thereafter. What does continue throughout all this, as much as the Institute on Aging will phase out, is the work from our Brilliant Corners partner. And so that's the housing retention services. And those continue for those members that actually have contact with Brilliant Corners vis-a-vis the housing. And I'll get into that in just a little bit. And one of the things that we have understood is while we may identify a housing solution for somebody in transition, the other key piece is helping them stay there and helping them be able to remain independent in that housing solution. Speaking of which, then our housing strategy, what we've done is take a look at the various services. I had mentioned the ability to help folks stay in housing. However, the components of that include an owner-resident liaison process where we help our members actually manage that relationship with the landlord, if that was the case for scattered site housing, for example, or if they already had an existing apartment or existing home, to be able to liaison between any other agencies and how to begin to do that. They also manage a housing portfolio for us to make sure that we do have a steady availability of various housing options for our members as we are transitioning them. They also take a look at the unit in terms of habitability, and they do wellness checks for us. And they are available on call 24 hours in case there are any other issues that pop up that are not necessarily related to that person's health conditions. It's all about just being able to live safely in that home. Our targeted residential settings, we've had quite the range from helping someone maintain their own existing home or apartment. The other piece is affordable supportive housing. We do have also scattered site housing as well as assisted living. As a result of this, we've been working closely with our County Department of Housing and Housing Authority for set-asides. One of our latest successful projects was with Haslund Village, and being able to move 7 folks over there, and they can't just be any happier being able to go from a long-term care setting to their own place in a beautiful setting. We've also been working on any waitlist management around Section 8 housing vouchers, and are looking further to partner in terms of opening up housing stock. As you can imagine, with San Mateo County in the Bay Area, housing is quite the issue, and vis-a-vis pricing and expenses, and we want to be able to preserve and identify housing stock for our members. Now, I described a lot of the processes and what we're doing, and one of the things that we have been doing as well is actually evaluating the impact of our program. And we do have some preliminary data. And we've been taking a look at, for the folks that we have transitioned out, and I'll have those numbers in a bit, that we've actually realized some savings. So as an example, that first segment of population, the long-term care residents that we've been working to transition out, the pre-transition per member per month cost that we've calculated thus far has been about $16,000 per member per month. Post-transition, that cost drops down to $5,130. That's for the long-term care residents in terms of going back to the community. The skilled nursing facility diversion, as a comparison, the pre-transition cost was $7,300 about, not surprising, and then post-transition was $4,740 per member per month. The community diversions, that segment, their pre-transition cost was about $5,600 per member per month, and then post-transition, the per member per month cost was about $2,500. Now, that's wonderful, and we're hoping to continue to expand that and hopefully continue to build upon that. But of course, then we have the actual stories for our members. And these, I think, highlight just the impact that we do make for the folks that were able to actually transition out. One particular case, so this person had a stroke, and that landed him in a skilled nursing facility, unfortunately, for over a year. He actually had his own apartment and was about to lose it because he had been out of his apartment for quite some time. Our housing partner went in and helped him prevent an eviction so that we can return him to his apartment. In addition, though, we needed all these other services to help him stay in that apartment. So we helped him with modifications, but also provided a bunch of other supportive services and got him into a CBAS program. In addition, we reconnected him to the community. He was very much active with his church and in the Filipino community, and we were able to get him back there. So whereas we're able to also to show these savings, we also do know the impact on individual members, and we have those stories. In addition to the individual impact, we have seen, as part of our goal, actually improvements in the system, efficiencies in getting services much faster, getting incremental services, and really a tighter coordination among the various agencies that would work to support our members in the community. As an update, our project launched about 15 months ago. We've been operating quite successfully within the original scope. We do have our core group every other week, and as well as administrative meetings to manage this. We continue to identify new ranges of services and support, as well as try to break down those barriers that prevent folks from community living. Since the start, we have 146 members enrolled, and 71 have transitioned. And the three various targets in terms of, I mentioned, the long-term care transitions, the SNF diversions, and community diversions, it breaks out into about 60% long-term care transitions, 20% SNF diversions, and 20% community diversions. We do have a referral pipeline that's growing, and as a result of growing popularity and more and more press about what we've been doing to a lot of stakeholders, we have a list growing in terms of the referrals, which has been great. We are working with our case management partner to increase staffing to be able to facilitate more transitions into the community. In terms of our budget, our actual expenses have been 30% below our actual fiscal year targets. This is getting us then to our phase 2, our outlook. And one of the things that we've gotten to a place in terms of our operations and some of the early outcomes, we now have wanted to grow the program a bit further. And so the keys there are we want to enhance case management capabilities, a dedicated project manager, augment the program scope and the intake criteria, and continue to leverage housing partnerships, as well as operationalize CCS, our pilot elements within the larger programming. We are also looking into a peer mentoring program and really connecting folks as a way to really address that piece of that disconnectedness that occurs in institutionalization, and as a way to really help people connect to each other and to the community. In addition, we want to have ongoing ways to engage with our providers about this program and to really be able to maintain that pipeline. So thank you very much in letting me share about our community care settings pilot.
Thank you, Dr. Esquerra, for that presentation. We have a few minutes before we resume with the rest of the presentation for some questions for Dr. Esquerra. If you have a question for Dr. Esquerra, please press 1 now. Our first question comes from Nancy Murish. Nancy, your line is open.
This is actually Gary Passmore at the Congress of California Seniors on Nancy's line. Doctor, I've got two questions. One of them is you cited some numbers, I guess what I would call before your service was used on a per member, per patient basis, and then afterwards. Does your second set of numbers, what you spent after this set of interventions, reflect the cost of your program, or is what you're doing, the cost of it completely outside of those sets of numbers?
Great question. And the numbers after the post-transition numbers actually reflect all costs, and so that includes our program and our staff. Just to let you know too, because we are the point in which we do the comparison, pre-transition, we also do have some program costs involved because our case managers are already working with the member to facilitate the transition. So that's also included in the cost pre-transition.
Thank you, Gary, for that question. Our next question comes from Hattie Hanley. Hattie, your line is open.
Hi, I just absolutely loved that presentation, and I'm wondering if you can talk a little bit about the breakdown of the different diagnoses of the patients that you're helping with this innovative model. And I'd like to learn more offline about that stroke patient and possibly feature that in a future Right Care Initiative University best practices.
So happy to talk offline. Thank you. And so we can compile the general diagnoses that we have managed, but it's actually been a wide variety. We have seen things such as stroke patients, but also we've had folks who have suffered from cardiovascular issues, behavioral health conditions, surgeries that have occurred. It's actually been quite the wide variety. What we've conscientiously done is not be condition specific, but be more specific to a population such as those living in long-term care settings or at risk for or getting into a skilled nursing facility. So, but we can get that information definitely.
Thank you. Our next question comes from Deborah Doctor. Deborah, your line is open.
Thank you very much for the presentation. It's heartwarming to hear the stories and the validation of what some of us have been saying and working on for, 40 years, that people don't have to go to institutions and can do better at home. I have one suggestion and then a couple of questions. The suggestion is that maybe to change the language about, it seemed like you were implying that in a continuum of care that an institution, say a nursing home, is part of a continuum of care, which kind of conflates the location with the level of care. I mean, people can have a higher level of care than nursing home care at home and, lower level of care if they're in an institution. So maybe I misunderstood, but it seemed like that was what was being implied. I wanted to let you know that on this issue of somebody losing their housing because they're in the nursing home, this is something we've been trying very hard to fix for a while and have a bill about home upkeep allowance that would do that. And I'm trying to understand what you actually pay for and what the interaction would be, say, with getting somebody on using our nursing facility acute hospital waiver, which has a 2-year plus waiting list for people in the community. So it's two different questions, but does the plan pay for services outside the scope of your required services? So if somebody goes on the waiver, then they have to go out of managed care, assuming they're a dual. And are these services only for duals, or are they also for non-duals in the CCI?
Great questions, and point taken about the continuum of care. So with regards to our housing strategy, our housing partners, Brilliant Corners, the funding that we use to pay for those services are actually coming out of care plan option services. And that is the mechanism under CCI by which we are able to fund services that are not the usual healthcare services that we would normally have. That's because those are benefits. So as a result, then our Brilliant Corners partner will then go out and provide services such as housing retention, liaison work that I listed, and has done a great job to really save potential loss of housing for a lot of our members that we've been able to transition, and actually been able to identify in creative ways housing stock, or even work closely with the Human Services Agency and Department of Housing with regards to Section 8 housing and extending the life of those vouchers. So it is a wide variety of things that they're able to do. All of that falls under the auspices of care plan options. With regards to your other question in terms of, actually I'm now blanking on your other question.
Deborah, your line is open. Go ahead.
Okay, thank you. I was asking about whether you're able to use the nursing facility acute hospital waiver as to pay for services in lieu of the equivalent institutional care. How are you paying, for instance, if somebody needs nursing care at home or services beyond IHSS, such as waiver personal care services? How are those getting paid for?
Right. So that all falls under, so our partner, the Institute on Aging, helps us manage a lot of these other pieces. There's a combination of, like I mentioned, the care plan options, but also using the various waivers that are available to a particular member. And so we utilize that as much as possible, and they do quite a good job of blending a lot of these sources. And I just remembered that other part of your question about who is eligible for this population. And yes, we do offer this for our members who are part of CalMedi Connect as well as part of our DSNP, but we also provide it for our folks who are Medi-Cal only, that are part of our seniors and persons with disabilities by definition.
Thank you, Deborah, for that question. In order to make sure that we get through the rest of our presentation, we're going to move on. And thank you, Dr. Esguerra, for joining our call and presenting. If folks have any questions for him, you can also email info@calduals.org, and we can convey the questions to him. I'm going to turn it back over to Sarah.
Thank you. So a couple more updates for today. Last week, CMS, or the Centers for Medicare and Medicaid Services, did release an evaluation report that some of you may have seen. It contains early results of the dual eligible demonstrations across the country, including the CCI, which is California's demonstration. CMS did contract with RTI International to conduct interviews, focus groups, and collect qualitative and quantitative data for the reports. And this is the first in a series to be released over the course of the demonstration. The report looks broadly at the first 6 months of the demonstration operations in all 7 states where the demonstration was live before May 2014, which does include California. The report describes the range of activities and early experiences in implementing these demonstrations and includes information about specific successes and challenges encountered. The report is a great resource for stakeholders who want to better understand CCI performance, particularly as compared to other states. It particularly calls out work in California on the strength of our stakeholder engagement process, which includes significant stakeholder input on the revised CalMedi Connect notices, as well as the strength and independence of the CCI Ombudsman program. Finally, the report recognized California for its commitment to continually examining and trying to improve the program, as is evidenced by the significant research underway thanks to the SCAN Foundation, including the field survey, rapid cycle polling, and the University of California focus groups that I talked about a little bit earlier. This will be very helpful as we continue to work on opportunities for improvement, as also outlined in the RTI report, including strengthening care coordination and educational materials for beneficiaries. RTI will continue to work on comprehensive annual reports specific to each demonstration state that will be rolled out. California's Department of Health Care Services is committed to transparency throughout the duals demonstration, and we have been sharing much information as a part of that commitment. While many of these findings are preliminary, they do provide information that we can use together with health plans and stakeholders to respond to challenges and further improve the experience of coordinated care for dual eligible beneficiaries. So building on that experience that we talked on earlier in today's call. So quick update on enrollment today. The latest CalMedi Connect enrollment dashboard that's posted is online at calduals.org. It is from December. We are working to finalize the January dashboard. Overall, as of December 1st, we have 115,743 beneficiaries enrolled in the CalMedi Connect plan across the CCI counties. That has a high end of 44,655 in LA, and then 4,354 in Orange County, where passive enrollment continues. You can find additional information on enrollment and disenrollment by county, race, ethnicity, and language on the full dashboard online. And as a reminder, passive enrollment did end in Santa Clara on December 1st, so Orange County does continue with passive enrollment and is our only county that has passive enrollment at this time. Speaking of words to raise awareness, I also wanted to provide an update on some of our work to reach ethnic physicians, which has been a big focus of ours lately. As we've discussed, the CCI team at Harvard is working with the CMA Foundation of Network of Ethnic Physicians Organizations, or NEPO, to conduct some targeted physician outreach and education across and around CalMedi Connect. Since our last update call, Harvard did collaborate with NEPO on events for the Korean American Medical Association in Los Angeles and the Indian Medical Association of Southern California in Orange County. More than 50 physicians attended each event, and attendees have been eager for information and lacking key details about the CCI, so very good opportunity for us to provide education about the program. This was evidenced by numerous requests for further support following each event. These events are tailored specifically for physicians and provide a great opportunity to connect with and hear from physicians of diverse backgrounds. Our work with NEPO is furthering our understanding of what information physicians are lacking and highlighting the ongoing need for this education, so it has been very helpful. We're continuing to look for ways to work with CMA and NEPO to engage members of their organizations. Also, as always, the Harvard CCI outreach team is available to deliver presentations and our webinars, come to events, help educate providers in CCI counties, so please let us know if you or your area is interested in an event. We always welcome ideas for new opportunities to reach physicians, caregivers, and other non-medical providers and feedback on this work. If you have some ideas, please reach out to us and to the Harvard team directly or send an email to info@calduals.org. Finally, wanted to just talk a little bit about some new materials. wanted to provide a brief update on some of the revised materials that we've talked about before or that you've seen for comment. The revised CalMedi Connect and MLTSS Guide and Choice Book and CalMedi Connect and Beneficiary Toolkit. First, I want to start out by just thanking everyone for your thoughtful review and feedback on the toolkit. We got a lot of feedback, really helpful, appreciated your comments and your input. We know how important this is to all of you, and it's really important to us that we do it right and that we make sure that we obtain your input to make sure that the information is helpful to our beneficiaries. We are committed to getting these materials right, and as a result, we're currently preparing to undergo some next steps in terms of the materials, and we'll be putting them through user testing in partnership with UC Health Research for Action Center. Both the toolkit and guidebook will go through user testing. So with that was today's agenda. I know we had a lot of information that we provided to you. Want to thank Health Plan of San Mateo for their presentation, and we will open it up for questions.
Thank you, Sarah. If you have a question, please press 1 and we will get you on the list. So if you have a question, please press 1. Our first question comes from Rena Cruz. Rena, your line is open.
Thank you. The material that's going out for user testing, is that the material with the comments already taken into account that was submitted by stakeholders, or is it the original material that went out before comments were submitted?
So the materials that will be going through user testing will reflect the stakeholder comments. Those red line versions will be up on CalDuals as soon as we can get them up there so folks can see what edits were taken. UC is then going to take the revised toolkit and put it through their own make some recommended edits before it then goes into user testing as well. And this is partly why we're so excited to be working with UC. They have a lot of experience developing materials for beneficiaries, and so we're going to be able to use and leverage that expertise.
Thank you.
Thank you, Rena, for your question. Our next question comes from Angela Ukiru. Angela, your line is open.
Okay. I was really excited to hear about what San Mateo is doing, and I wondered if there was anything in writing that we can actually read. I mean, he talked so fast, and I was trying to take notes, but it sounded so good. Is there anything or any reference anywhere that we can access to read a little more about the program?
We'll follow up with San Mateo, and if we can get materials from them, we will include it in our next monthly update and post them on CalDuals.
Thank you.
Thank you for your question. Those are the only questions we've had so far. If you have a question, please press 1. We'll get you into the queue. It looks like we don't have any questions. As always, you can email info@calduals.org your question, and we will respond. Thank you for joining today's call.